Dr. Cashman, if the public wants to direct funding specifically to your research, how is this done?
What a wonderful question. Before I answer that, I want to make it clear that these are technologies that were developed and owned by UBC. UBC owns the patents for these, but they have been exclusively licensed to a company. Just like David, I've started a company called Promise Neurosciences, and I, as a disclosure, I own stock. I am compensated by Promise, and there is the potential for conflict, so a conflict of interest. So what I'm going to tell you is that if there is, if after knowing this information, there is interest in contributing to the program at UBC, that's best done through the VGH Foundation or the UBC Foundation to target the work specifically for the development of these A-beta oligomer therapeutics. Perhaps I could have Hakon say a few words because I might not have the best words to describe this sort of funding mechanism, but I'm sure he does.
Well, I don't have very much to add, but Neil and I and the group, we're trying to develop a program at UBC where discoveries such as Neil's can rapidly enter a clinical study, which really is the goal here, and that costs a lot of money. And I think a contribution to a program would be to fund early clinical trials of Dr. Cashman's compound. So that would be through either our clinical operation or through the VGH Foundation, who's present here today. So I echo, it's a wonderful question, and we would certainly love to continue a dialogue if that's of interest.
Yes, I would like to underline continuing the dialogue, but while you have the microphone, Hakon, the next question is this entire seminar presentation available to watch online?
Yes, it's recorded, not live, but it will be posted on our website, which is fairly easy. We can maybe email that out, or maybe I'll put it on the screen when you come back after lunch, so you can write down the web address.
Thank you. The next question is, Dr. Patrick McGeer at UBC has patented a saliva test for early detection years before the onset of the illness. Could we have comments about this?
So we are certainly collaborating with Dr. McGeer. He has not yet tested extensively before symptoms. So his study was in patients with Alzheimer's disease. There were a few that did not have it. So we are now doing another study with Dr. McGeer to look at both symptomatic and early asymptomatic patients at risk to see if that's a diagnostic test that could be used, very similar to Dr. DeMarco's work on CSF. So stay tuned. We may be able to give you an update next year about that.
Yeah, and I would just add, we talked about those mountains to climb. So that's one of those really exciting new studies, and that further studies need to take place before that's ready to move into patient care.
Dr. DeMarco, while you have the microphone, the question is, where is the CSF or cerebrospinal fluid diagnostic test available?
So it was developed at St. Paul's Hospital here in downtown Vancouver. So that's where we're running the test. We're looking at how we can roll this out with the clinic here at UBC. So the best I can say is as it becomes available, we'll certainly make that more widely known.
For there again, financial resources will be required to enable that, I assume.
Yeah, certainly. So we're trying to climb the last peak of that mountain. We're a little short on funds. The Paul's Hospital Foundation has stepped in to help us try and recruit some more funds so that we can make this happen and make sure that we can roll it out into patient care.
This is a question for Dr. Vocade. Would OGA inhibitors be useful in treatment for diabetes?
I guess the short answer is no. Yeah, no, that's not likely, actually. But I won't go into a lot of the scientific background on that.
But it's a good thought. It's a good. Dr. Louis Ambrose, how far do the walkers go each day? Is the walking continuous?
So in terms of the intervention studies we conducted is a build-up. So we recruit people who are previously sedentary. So initially, the first 2 months, they walked in bouts of 5 to 10 minutes. We had a rest and we continued. And by the 4th to the 6th month, they were walking continuously up to 40 minutes per day. So that's 3 times per week.
And there's also a question for Dr. Cashman. What are the implications for blood transfusions given the latest prion research?
Yeah, so that is truly an excellent question. So I'm talking about infectious prion diseases like Creutzfeldt-Jakob disease, like animal, bovine, spongiform encephalopathy, mad cow disease. These things are known to have the infectious particle that can be passed from human to human in biofluids. Blood transfusion has transmitted variant Creutzfeldt-Jakob disease in the United Kingdom. However, and this is a huge however, the neurodegenerative diseases I was talking about, like Alzheimer's, Parkinson's, and ALS, they're kind of borrowing this concept of propagated protein misfolding, but they do not have an infectious life cycle. So you can't contract Alzheimer's disease from contact with a sufferer, even intimate contact, even blood transfusion. So this is mostly the idea that some of these diseases propagate via prion-like mechanisms is very important scientifically because it gives us new targets for treatment and for diagnosis, but there are zero concerns that this makes these diseases like Alzheimer's, Parkinson's, and ALS transmissible through blood or blood products or surgical procedures or the other things that the real prion diseases can do.
Now, here's a question that we all can think about. It's actually several questions in the same theme. But the relationship between caffeine, nicotine, alcohol, and cognitive decline. And the uppers or the downers, I guess this is the question. But this is such a common thing that is continuously looked at in epidemiological studies. And I know that it's 5 lectures in itself to answer these questions, but I wondered just off the top if people could volunteer to talk about alcohol, nicotine, and caffeine in terms of mild cognitive impairment, dementia, and not having anything happen at all. Who wants to start? Oh, well, Robin's going to talk about that later. So, then we can have a brief hint that you can continue with, Robin. Thank you.
I think we'll leave that to Dr. Shung. That sounds great.
Does anyone else want to have a comment at this point from the basic science angle?
Well, I can just say one thing about caffeine. There's been a lot of studies recently on caffeine, and it looks like it's probably beneficial. There's a compound. It's actually not caffeine, though. It's a compound in coffee that seems to be what's effective, because caffeine-free coffee works as well. So stay tuned, but there have been very large studies on coffee with caffeine, not just Alzheimer's, but across the health spectrum. And so far, the more you drink across measures, it seems to be quite beneficial. In some sense, paradoxical, but coffee seems to be good.
Okay. Well, two more questions. And one is closer to the topic that we've been scrutinizing, and they're questions related to research involving the PET scan, about using it for early detection, or even what is the accessibility. Can I walk into my doctor and get a referral to have an amyloid PET scan?
The answer is yes and no. There is so first of all, public funding is not available for PET imaging in British Columbia at present. You can get, on a private basis, this FDG PET, or fluorodeoxyglucose, which is the glucose PET. That will cost you $3,500. It does give you quite a bit of information about your risk for various dementia, including Alzheimer's disease and frontotemporal dementia. Mind you, please discuss that in detail with your specialist before you go that route, because there are some implications about knowing disease risk when there's no clear intervention, and that's a very important point to us. So make sure that there's long discussions about that before going down that road.
Can I
Yes,
add
go ahead.
something? Well, Hakon's definitely the expert in imaging, but certainly through our conversations with the clinicians, that was in part our motivation for undertaking diagnostic testing in CSF, because it really comes in at a fraction of the cost of imaging. So that's certainly a really attractive factor about approaching how to get public funding to undertake that testing. And it's the same as Hakon highlighted. I should have probably highlighted this earlier, that our test really is not something that should be driven by patients, but really physicians saying, this is the added piece of information I would need to make the diagnosis.
Now, this question is related to thoughts about microbiome and involvement in Alzheimer's disease. And as people have probably read, microbiomes are very topical. Now, is that going to be in your talk? Did anybody want to make a comment about that?
Very, very briefly.
Okay, very briefly. Well, so we're going to hear about that. And are you going to mention lithium too? No, lithium. Lithium commonly comes up, and there's one question related to the impact of lithium. And I don't know if this has been studied at all related to any of your protein folding or sugar molecules or anything like that, but it often comes up about whether or not this is a help or a hindrance or what. Anybody have any comments about that?
So in a disease that I'm clinically obsessed with, ALS, a poorly designed lithium trial actually made it to the pages of the proceedings of the National Academy of Sciences, showing a benefit, and when it was repeated in 4 countries and I don't know how many groups around the world at great expense, it was found not to be effective. There is a scientific rationale for lithium being involved with the disposal of misfolded proteins, but it didn't pan out as far as patients went.
Well, thank you.